Hi, everybody. I'm Dr. Hal Skopicki. I'm the Chief of Cardiology here at Stony Brook Medicine and also the co-director of the Heart Institute at Stony Brook. As many of you already know, heart disease remains the #1 cause of death in both men and women in the United States. And high cholesterol is one of the leading causes of heart attacks, strokes, and loss of limbs. In the United States, there's about 800,000 heart attacks each year, one occurring every 40 seconds, and about 1.5 million heart attacks and strokes. 95 million people in the United States have high cholesterol. With me here today for this Stony Brook Facebook Live event are 3 experts in the prevention of heart attacks, the diagnosis of high cholesterol, and the specific management of that disease. So to get the festivities started, if you wouldn't mind introducing yourselves, let's go around the horn.
Hi, my name is Shahana Chowdhury. I'm the nurse practitioner for Stony Brook Center of Lipid Management.
Hi, my name is Abid Rahman. I'm the Associate Director of the Advanced Lipid Center at Stony Brook University Hospital. And I'm originally from New York, and I'm very passionate about cholesterol, given our risk factors as well as a family history.
My name is An Khan. I'm the director of the lipid or the cholesterol center. I'm also an interventional cardiologist and see what cholesterol does to you. And I'm happy to be here tonight.
So I'm going to start off with a bunch of questions that we've kind of pulled from the audiences that we've worked with in the past. And I'd ask you to hold some of your questions initially so that we can get a little bit of information in. But really, the whole success of the evening is going to be due to you guys actually asking us questions and allowing us to kind of talk about your individual needs. So I'd like to start off with the good first. Sahana, if you wouldn't mind, can you kind of explain to us what is cholesterol and why we need it?
Sure, Dr. Skopicki. So we all know cholesterol is a waxy fat-like substance that our body produces naturally, mostly in liver and also from the food that we eat. It is important because it is important for normal functioning and structure of the cells. It also helps to make hormones and digest fats. Good cholesterol is good, but bad cholesterol, we always have to worry about it. So too much cholesterol is not good for us.
So we take cholesterol in our diet, but if we didn't have cholesterol in our diet, let's say we're vegetarian and we don't have access to proteins, does our body's own liver actually just make the cholesterol instead?
Yes, I think Dr. Rahman can answer that question very well.
Yeah, absolutely. So, our liver is designed to produce cholesterol using the fats that we take in, as well as the fats that are just stored in our body. And the liver takes that and produces the cholesterol just to create the things that Shahana mentioned as a normal product. Sometimes due to genetics or depending on how much cholesterol or how much fat we take in, our liver can produce too much cholesterol as well.
So when we take in too much cholesterol, tell us, how that actually goes on to cause heart attacks and stroke.
Yeah, so when you take in too much cholesterol, or sometimes, if you might have the genetics for it, you might produce too much cholesterol. The problem is too much cholesterol is bad. And when that cholesterol builds up, it just builds up and gets circulated in our circulatory system. It travels in the blood. And as it travels in the blood, it constantly is damaging the arteries of our body. So if it kind of like damages the walls of the arteries of the heart, it'll constantly go in there, build up, and a plaque will form. And as that plaque builds up, it clogs up that artery. And inside the heart, it'll clog it up and eventually start causing chest pain, shortness of breath. Sometimes it'll get to the point where it's making you take like 2 steps and you can't do anything further without pain or shortness of breath. And if that plaque ruptures, then all that gemish that's inside of that plaque will spill out into the artery, and that's when a heart attack happens. Same thing in the head, the circulation to our neck, going up to the brain. If it builds up there, then we're going to start having signs of maybe confusion, maybe periods of where we're passing out. And then if it gets to the point where it completely occludes that artery, we could get a stroke. And then the leg is another place that we have to consider, or all the other organs in the body. And that's what we call our peripheral system. And when it builds up and the plaque builds up over and over due to repetitive damage and buildup of plaque in the legs, you'll eventually start getting pain as you walk. And then you could start seeing your feet start to get very cold. You start losing the circulation, you'll get infections, and next thing you know, they're cutting off your leg because it's become infected and diseased from poor circulation, all from too much cholesterol.
Tom, and I have to say to you, that's one of the best descriptions I've ever heard about how cholesterol causes heart attacks, strokes, and blockages in the blood vessels to the leg.
Thank you so much.
So, Sahana, if you wouldn't mind, when a patient or a person goes to get a cholesterol test to measure the cholesterol in the body, what are they actually measuring? What's the actual testing telling us?
So cholesterol is made up of different components. What we're actually measuring is the different components, the HDL, the good cholesterol, the LDL, the bad cholesterol, the triglycerides, which is also fat in the blood. And again, there is another thing that we also measure, which is LDL, but with elevated LDL, which is called more severe high cholesterol. And that we'll get into, it's called familial hypercholesteremia. So when we talk about the HDL, which is a good cholesterol, which what happens, it actually moves the bad cholesterol, which is the LDL, from arteries and back to liver. When we talk about the LDL, we actually depends on the risk factors on a patient. And when we talk about the triglyceride, it plays an important role because higher the triglyceride level with high LDL and low HDL can cause a risk for cardiovascular disease. And then what I said about the familial hypercholesteremia is that when you have extremely elevated LDL, then it's a genetic condition, and we have to send patients for genetic testing because it's an LDL that is developed in the family with high LDLs, and they have since a young age, I would say, and it's very important because if it's not taken into consideration with aging, it gets worsened.
So summing that up, there's the total cholesterol, which is just a large number that describes everything.
Yes.
There's the LDL that you said was the bad cholesterol.
Yes.
That elevated, it puts the cholesterol into the arteries. The HDL, which is the good cholesterol that pulls it out. And then the triglycerides, which kind of circulate in your body and at very high levels can cause something bad to happen, not necessarily to the heart, correct?
Yes.
So how I think that, I think that it's important to remember that our body regulates the amount of cholesterol it produces. So it produces it locally, it controls the amount of cholesterol needed, and so the cholesterol we find in the bloodstream is usually cholesterol in excess that's not necessary for our body's function. It's not a normal cholesterol to be there that's used by our body to produce cell membranes and hormones and estrogen and progesterone. That's not why it's there. It doesn't reach the brain. Our cholesterol in the blood doesn't go to where it's supposed to function. So when we detect it, it's a marker of the risk that you just heard about of having heart attacks, strokes, and blocked arteries and other organs in the legs.
Wow, that's excellent. So if you wouldn't mind then, Dr. Khan, continue on and tell us, so when we have these cholesterol levels we're measuring, but we're looking at heart risk, right, and cardiovascular risk. Can you tell us a little bit about how your physician should be calculating the risk of you having a heart attack, stroke, or blockages in your arteries?
Sure. So, when you come to our clinic, we don't just look at just the number, that cholesterol number that you have. It's in the context of your overall cardiovascular health. There are risk estimators. They take into account your age, your gender, your other comorbidities, your blood pressure, diabetes, other things that predispose you to develop heart disease on a background of high cholesterol.
What about smoking? Does smoking predispose you to getting cholesterol in your arteries?
Absolutely. So I think that smoking behind high cholesterol may be one of the highest risks for developing heart disease and stroke and what we call atherosclerotic heart disease, or ASCVD.
So you walk into a doctor's office, they take all these factors into account, and they come up with a risk. They define whether you're a high, medium, or low risk for developing heart disease, right?
Right, that's correct. And when we put that number that you have for the bad cholesterol, we put it in that setting of your risk. In other words, I had a patient come to my office with a cholesterol of 150, 145. He's middle-aged. His risk was intermediate. And, I can tell you it's a discussion. You can talk to him about medication, or you can do other things. I'd actually ask my partners here, Sahana or Tamid, what would you do? You have a 45, 50-year-old LDL of 145, 150. His risk score is intermediate. Do you start him on medication? I'll tell you what, yeah.
We estimate the risk, and definitely if it's intermediate and with other comorbidities, we start them on statin.
So, I usually do, add some tests to that situation. So the basic study is getting the cholesterol panel. The next step is putting it in the context of your overall ASCVD risk or cardiovascular risk after estimating it. And then adding, when necessary, additional tests. There are other blood tests that we can look for that would be markers of heart disease or markers for risk for heart disease. Those are inflammatory markers and other particles that were not tested in the standard panel. Sometimes we need imaging. So in that patient I just mentioned, I ordered a calcium score. And if he has absolutely no plaque formation in his heart, then maybe it's safe to watch it and implement dietary changes and lifestyle changes. And maybe, if he already has evidence of heart disease, then I might start him on statins or therapy already.
So I think, go ahead.
Yeah, oftentimes, with that patient that you described, Dr. Han, you take this intermediate risk patient and, like you said, maybe consider doing a calcium score or and seeing if there's plaque or not. However, oftentimes, even before they want to try that, they want to address their cholesterol panel first. And they'll often request that we want to try lifestyle changes, which is definitely the cornerstone of lowering your cholesterol. And I sometimes would agree with the patient, hey, sooner that we tackle your high cholesterol, the better. You're at intermediate risk for heart disease, but I'm willing to give you a chance to tackle your cholesterol with either losing weight, quitting smoking, or addressing what you're eating every day as well. And then come back, we check your cholesterol again and reassess your risk at that time. And if you're still falling in that intermediate risk, that's often when I would go in for those added tests if you're still unsure if you want to try the medication or not.
So let me get this straight. I come into your office. I don't have my cholesterol checked. You get my cholesterol checked. If I do have it, you take a look at my cholesterol. That's just one factor. Then you're going ahead and saying, I'm going to put a whole bunch of risk factors together that are particular to you to assess your risk of getting blockages in your arteries or having a stroke, heart attack, or clot in your blood vessels. You then go ahead and say, I'm high, intermediate, or low risk. For the low risk people, I'm hearing you say that you're going much, much more towards lifestyle. For the higher risk people, you may be taking them in another direction that's more aggressive. But that group in the middle, that intermediate risk group, you go ahead and you get a few more tests on those people to really see if their arteries can put cholesterol in it or have the capacity to do that. And once you do that, now you have a real picture of what this patient looks like. And at that point now, we're trying to go ahead in with the lifestyle. Is that a good summation?
That's correct. That's correct.
So let's start off with those lifestyle changes, because everybody talks about the fact that we have to do so many things to try and preserve and protect our health. So Sahan, if you wouldn't mind, kind of take me through what it is, what are the suggestions that you make to patients in order to be able to alter slightly their lifestyle in order to manage high levels of cholesterol.
So the first thing that comes into our mind when we talk about lifestyle is our eating habits. So we tell our patients not to eat bad. That's the first thing we tell them. Try to avoid foods that contain more trans fat, saturated fat, that are seen with fried foods, junk food, prepackaged foods, foods that are processed like pizza, burgers, and fries. Of course, these are all sounds very good, and I'm sure people loves those, but we have to avoid them to reduce our risk. We have to avoid high sugar content beverages such as Coke, some juices. We have to be smart, think smart, and eat healthy. We should eat plant-based foods, mostly vegetables, fruits, salad, whole grains, soluble fiber that are found in oats, some seeds. And of course, you can eat meat, but we have to limit red meat, which is important. Anything in moderation is good. We have to make sure the meat that you eat should be lean, either grill it or bake it.
All right. So you mentioned a couple of things in there that maybe for our audience we need to explain. So you mentioned trans fats and saturated fats. Dr. Rahman, would you mind kind of letting our audience know the difference between trans and saturated fats?
Yeah, sure thing. So, it's really like nerd words, scientific words that based off of like how the fat was turning, they gave it the label trans fat. End of the day, trans fats and saturated fats are very packed fats. These are fats that are very dense, and they get packaged very easily and get very easily layered. And the more you have of that, the easier it is to make a denser cholesterol that can hurt your arteries. What we want is more unsaturated fats. And unsaturated fats are like those omega-3s or omega-6 fatty acids that you hear about all the time and that you read on the labels of like your omega-3 nuts, or like this milk is fortified with omega-3 fatty acids. These are unsaturated fats. And the unsaturated fats are really good because they're not packed with all the fat molecules, and that helps prevent cholesterol from really building up, and actually can help improve your cholesterol profile when you switch from more of a diet that's rich in saturated fats, trans fats, like I'm going to Popeyes every day, and going to a more unsaturated fat, such as more foods with nuts, fish, and more of like a kind of like a Mediterranean style diet.
Yeah, so I think everybody's bringing up these really great points. Dr. Khen, you see, patients in your role as an interventional cardiologist after their arteries have really kind of gotten filled up with cholesterol. Can you kind of summarize just conceptually, how do you talk to patients about, the goals of what you're trying to do with their diet and get them motivated, to take control of it?
So, I think you have to separate for them the role of the diet and the lifestyle changes from the role of reducing their cholesterol or reducing or taking medication for the cholesterol. They're two independent things. Your diet may not reduce the number that you get on your bad cholesterol, but it will reduce your risk. So it's imperative that our lifestyle is changed. And that includes a diet that is sustainable, that you can adhere to, and not a diet that is going to be aggressive for a short time and then lose its effect as you go. I think that one of the key things is to have a discussion about what your goals are. Are you planning to lose weight? That is a very different diet than just having a healthy diet. Weight loss diets may not be healthy. They may raise your cholesterol. Are you treating a certain condition? When patients come to me, those are not patients who are usually healthy and want to just have a healthy lifestyle. These are patients with high triglycerides, high bad cholesterol, diabetes, and high blood pressure. If you have high blood pressure, you may need to stay away from salt. It's a DASH diet. If you have high triglycerides and diabetes, it may be reducing the amount of carbohydrates. But what you need to remember is that those fad diets, the low cholesterol or low fat or low carb diets, they're not sustainable and they're not healthy. As you just heard, they're good fats and bad fats. They're good carbs and bad carbs. If you're going to take away the soluble fiber and carbohydrates, the vegetables and the fruit, you're doing the wrong thing. If you're going to take the healthy things you find in fats, the healthy fats you just heard about from Dr. Rahman, that you do find in nuts and oil and olive oil and canola oil and seeds. If you take away those, you're not being healthy, you're not eating healthy, you won't reduce your risk. So it is not that strict bad diet that you go to that you call, those name diets that we chase. It's a combination of common sense and good healthy diets.
So one of the things I think that we all face in practice is the patient comes in and they say, this is what I eat, this is my diet, this is what's on my shelves, this is what's in my refrigerator. Is there value in going to a center that specializes in cholesterol for the dietary education? In other words, to get them from point A to point B, C, D, E, and F in a stepwise fashion, as opposed to just throwing, a goal at them or saying, here's the Mediterranean diet, follow this.
Yeah.
So I agree with that. And the approach is going to a specialized center, like the one that we have at Stony Brook with the Heart Institute here with our lipid program. It's constantly readdressing those goals, and kind of like at every visit, we talk about your diet, we talk about your lifestyle, because at the end of the day, we could throw you on any medication, we could tell you to follow any diet, but we have to talk with you and come up with an individualized plan. So it's important because at our center, we take a multidisciplinary approach. I will talk to you about it with a diet at our visit. Our NP, Shahana, she will constantly talk to you about what's going on with your diet, as well as if you can't meet me, you meet Dr. Hen. He will talk to you about the diet. And then we have our nursing staff who will call you to see and talk to you some more about your nutrition goals. And if there's any further questions that you would need, we have a nutritionist that works with us as well. And we refer you to them to kind of get more further ideas of what diet works for you. The key is, like Dr. Hen mentioned, is finding a diet that you can stick to. You could choose any diet that you want. However, if you're making dramatic changes all at once, it's very hard to stick to it, and then it ultimately fails. So every time I see a patient, what my strategy usually is I take one thing that's bad in their diet and we switch it at that visit. The next person that interacts with them, they may switch another bad thing in their diet. I often address sugary drinks like soda and juice first to tackle the carbs in their diet, because those are no nutrition at all, and that will be the most bang for your buck right there and help change your factors. So again, having a multidisciplinary approach is the way to go, and constantly reinforcing the diet changes to help find you something that works for you.
Yeah, I really couldn't agree with you more. And I know in my spare time, I do a lot of coaching of young kids in their sports. And the thing that really has changed generationally is that when you used to sit around a table after the game having pizza, it used to be Coke, 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 and every once in a while somebody had orange soda. Now when you go around the table and you ask for drinks, they say water, water, water. So I think the concept that one of the worst things you could be taking in are those sugary drinks, in a lot of ways, really has taken hold among the young. And now we're just trying to get it to our generation. So we've talked an awful lot about diet, and it is a cornerstone. Does anybody want to comment about exercise and how that plays into both cholesterol, and does it raise or lower certain parts of the cholesterol tree, and also what does it do to heart risk in general?
So exercise again plays a really important role as part of the lifestyle changes. Sedentary lifestyle is a very risk factor for cardiovascular disease. So as per AHA guidelines or recommendation, 150 minutes per week of moderate intensity exercise, which includes, say, brisk walking or power walking, swimming, biking, or 75 minutes per week of high intensity exercise like cardio, is the recommendation. But not everybody can do it. So any exercise is good. You have to keep on moving. So even if you start with a simple steps, or count your steps, and go up to like 10,000 steps a day, that will reduce your cardiovascular risk.
So what you're saying is any exercise is good, and then having goals of working your way up to higher levels of aerobic exercise may be even better.
Yes, you're right.
It's
How?
one of those fun things that I always say to my patients is, when you go into the jungle, do you ever see a lion lifting weights? Or do you ever see a monkey doing sit-ups, squats, and push-ups? And the answer, of course, is no. But what you do see them doing is walking, running, swimming, climbing trees, and flying. It's all aerobic. And I think when you're trying to talk to patients about natural remedies for the ills that affect them, focusing in on the aerobic when they can, and when they can't do aerobic, kind of getting involved in a little bit of light weights might be the key. Do either of the two of you do anything else with your patients as far as exercise?
I do. I think I start with the basics. There are patients who just cannot perform a real meaningful exercise at the beginning. And sometimes it's asking them to make a small change into their routine. It's asking them to do a 5-minute walk just to create space in their routine that later on expands. If they walk 5 minutes every day, 5 times a week, at one point it becomes their routine. And you can build on it and say, okay, now you do 5 minutes and it's not an effort. Why don't you walk for 7.5, 10 minutes, or walk it a little faster? You can do more in those same 5 minutes. So at one point, that time that they dedicate becomes a real exercise. It becomes a power walk or a 30-minute habit that they exercise in. So that's one thing I do. Sometimes I offer them to buy a stepper, a device that measures their steps, and aim to increase their steps a day. The guidelines suggest up to 10,000 steps in a day is healthy, and so those are things you can do.
What about you, Dr. Rahman?
Yeah, so another thing, the highest risk patients are actually those that have already experienced an event. And it's tricky because once they've experienced their event, these are the people that are worried about exercising or increasing their physical activity levels, and they're just not sure how much they could really do. So it's these patients that honestly increasing their activity level just a little bit in a gradual approach would really help them out the most. So what I often do for like a patient that has heart attack or heart failure from coronary artery disease originating from like high cholesterol levels, I would often refer them to cardiac rehab programs, something that we have at Stony Brook as well.
So we've talked about exercise, we've talked about diet. We've touched on the fact about sugar. I guess two things that people have asked about in prior comments was, what about stress and what about sugar and diabetes? Does that play into or interact with your cholesterol levels to cause artery disease?
Absolutely. So stress is a big factor that can drive a lot of different processes going on at the same time. And we've seen that the higher amounts of stress that you experience in your day-to-day can actually affect your overall total cholesterol levels. The main factor probably would be lowering the HDL as well as elevating your LDL. The other thing with stress is there's a lot of inflammation that comes with stress as well. So it's not just about the cholesterol, but also your overall whole body inflammation, especially in the arteries. And it's that combination of higher cholesterol or abnormal cholesterol panel with increased inflammation in your arteries that will lead to an increase in your plaque burden inside of your arteries, leading to heart disease, stroke, or peripheral arterial disease. Your second question about the sugary drinks and the diabetes is very interesting. So they look at high amounts of carbs, and with the high amounts of sugar that leads to high carb intake, the more carbs you have actually has been shown to increase your triglyceride levels the most. And when you have higher triglycerides, that's higher fat in your body, that actually makes your cholesterol particles smaller and denser. And the smaller HDL particles, which is your good cholesterol, if that becomes smaller, what ends up happening is that gets eliminated in the urine. So you don't have that good cholesterol to kind of like counter your bad cholesterol levels. When the bad cholesterol becomes smaller and denser because you've been having high carbs, leading to high triglyceride levels. When that bad cholesterol becomes smaller and denser, that makes it easier for it to go inside the walls of the arteries and easier plaque formation in those arteries, leading to our problems with the cardiovascular system.
That was great. So I want to encourage everybody to start asking questions in our chat box at the bottom of your screen. Mary Ellen asks, what if you have high LDL cholesterol, high total cholesterol, but your HDL is high along with the LDL.
Yeah. So here's the answer. It really depends on the numbers and your overall risk profile. There is some misconception about HDL. We call it the good cholesterol. When it's really high, it actually has a detrimental effect. I won't go into detail of it. We call it a U-shaped distribution of the association with cardiovascular events. So when it's really low, you're at risk, and when it's higher, you're protected. When it's really high, you're at risk again. And so it really depends on what the numbers are. Sometimes there are genetic components associated with it.
So we've kind of gone through the risk factors, and we've said, okay, listen, high cholesterol levels causes cholesterol to go in. Diabetes causes cholesterol to go in. Cigarette smoking may cause the arteries to become more susceptible to getting cholesterol in. Your genetic factors may be causing more cholesterol to go in, especially that genetic group that they call familial hypercholesterolemia that really allows high levels of cholesterol in your body. One thing that we haven't focused on too much is a question asked by Jody, who said that if your blood pressure is high, especially the bottom number, is your body telling you something, and how does that tie into high levels of cholesterol? Of blockages in the arteries with high levels of cholesterol.
So it's a great question. The thing that we have to focus on is that we use the blood pressure as another tool for our risk assessment. The higher your blood pressure is, even if you have a well-controlled cholesterol, is associated with increased risk for cardiovascular disease. If your diastolic numbers, that bottom number, is consistently high, sometimes that could be a sign that your arteries are getting stiff from high amounts of inflammation, high amounts of plaque buildup in the arteries as well. So oftentimes it's a signal that, hey, we need to do something different to address that, whether it's exercise, diet, or maybe something to talk about with your doctor to start medication, because high blood pressure, high cholesterol, all of these are risk factors. And again, it's all that interplay leading to your overall cardiovascular risk to preventing heart disease.
So you've measured my cholesterol, you've measured my blood pressure, you've got me eating well, you've got me exercising, you've got me doing Tai Chi and stress relaxation, and now all of a sudden my cholesterol levels come back and they're still elevated, or I'm at an increased risk of developing blockages in my arteries and my cholesterol level's still elevated. Tamid, so how do you decide when a patient actually needs medication?
So yeah, it's always the number one discussion is, when do I start my meds? And we take that by looking at your overall risk. So oftentimes when we do the risk calculators, we try to get them at the low risk. If they start off at a low risk based off of our risk calculation, and then using those calculators and thinking about other risk factors that are not involved in those calculators, and we determine that they're low risk, I often tell them, hey, let's try lifestyle first, because we want to decrease your lifetime risk of having cardiovascular disease. So this is the time where we focus on your lifestyle management. If they fall into that intermediate risk category based off the whole risk assessment, it's a discussion here. And we talked about it briefly before, where I can offer medication if they're really worried, based off, especially if they have a family history, if they don't want to give up cigarettes, which again, you have to give up cigarettes. That's going to increase your risk no matter what. But if you aren't willing to do that, or you have a very scary family history, I would usually offer medication. Sometimes I'd be fine just doing lifestyle here as well for 3 to 6 months, seeing how you do with that. And if you've done everything that you can, oftentimes it's your genetics that are playing a role here that's just leading to your cholesterol levels not budging. And you just need some extra support with medication therapy. And I would recommend that at that time. The high risk patients are the ones that absolutely have to be on a medication therapy, in my view. Oftentimes we'll have a discussion, and sure, we could always try lifestyle changes first, and that's fair to get them to that intermediate risk if possible. But even if it's not, and if everything's well controlled, you've done everything that you can, and you still fall in that high risk, especially if you had multiple events in the past, like a stroke or a heart attack, you've had stents placed, you've had pain in your legs from walking, and you've been diagnosed with like claudication, then these are the patients that I stress that we've got to start you on treatment, because the longer your risk is going, the more risk you will develop and the higher the chance you will experience problems. So this is the patient group that I really emphasize of controlling their cholesterol dramatically.
So those patients where you go ahead and you say your arteries have demonstrated that you could put this cholesterol into those arteries, cause the blockages in the heart, cause the blockages in the leg, cause the blockage in the brain, they absolutely need to have their cholesterol levels made as low as possible?
That's absolutely correct. These are what we call secondary prevention. The patients that have already demonstrated that we've built up plaque or they've already experienced episodes of cardiovascular disease, heart attack, stroke, mini stroke, pain in the legs, things like that. These are the very high risk patients, and these are the patients that need to be treated right away.
And
So,
those, go ahead, please, Dr. Hen.
So, we started by describing what high cholesterol does to you. We described the burden of heart disease. We described the frequency of heart attacks, the consequences of not controlling your cholesterol. So I think that the first step is clarifying whether there is heart disease or whether there's atherosclerotic vascular disease, if there's plaque buildup anywhere in the body. So when a patient comes to me, besides checking his cholesterol, the first step is making sure he does not have plaque buildup already. I think that one of the things that are underutilized are the basic imaging studies, a calcium score, which is a CT scan, a simple CT scan of the chest to expose you to minimal radiation, less than a mammogram or equal to a mammogram or a chest x-ray. Getting a blood pressure cuff to your leg, it's called an ankle brachial index. Basic studies that tell me if there's plaque buildup already, that you deserve a more aggressive therapy. It's not, I think that you don't want to wait for things to happen knowing that you already have that process occurring. And it's true, when they're completely normal, you may have the chance to sit back and say, okay, I don't have plaque buildup yet. Maybe I can change things with lifestyle. So that's when I start medication. When I know there's plaque buildup, when I see it on imaging, or you've had an event already. If you had a heart attack, I don't want to see you in the cath lab again. It's just a matter of time before it happens. And so that cholesterol has to be driven down, and you get medication.
So connecting the dots, we know artery disease is, heart disease is the #1 killer. We know that artery blockages are the way that many people suffer from heart disease, and we know that cholesterol is an important contributor of it. So taking those people in that intermediate group where you're not sure, is it too early to start, not too early to start, and really understanding that group really kind of is where most of the difference that we can make in terms of improving people's outcomes.
I'd add one more thing. I'd add that I sometimes have patients who come to clinic and they tell me about all the other medications or all the other tests they do. They'll go through invasive tests. They do a colonoscopy or a cystoscopy. They're agreeing to do routine mammograms yearly. And they'll take medication that have side effects. They'll pay a lot of money. They'll take experimental medication for many other illnesses, including cancer, when cardiovascular disease causes more death than all of those. And so I think that there's maybe sometimes a resistance to work it up or treat it that shouldn't be there. We need to get over that hurdle sometime, or that it's really a discussion about what heart disease and high cholesterol does to you.
Yeah, so Tracy Marie asks a really good question. What age is it good to check your cholesterol levels?
So there's recommendations for this. If you actually go to the CDC website, they recommend the sooner the better. And starting at age 20, everyone should get a cholesterol check. However, the guidelines suggest that, you need to start screening even younger than that, because we've seen that if you have high cholesterol, even at a young age, even starting in childhood, you could start having signs of plaque buildup in your teenage years and your mid-20s and 30s. So what we recommend is, depends on your risk. If you have a family history that's very significant, like let's say premature heart disease, like your father has heart disease at like a young age, like less than 55, or your mom has heart disease less than 60, then maybe consider having your children checked as early as 2 years old to make sure they don't have those like genetic causes of very high cholesterol. The other thing to consider is, in younger adolescents or teenagers, even if they don't have the high risk, like a family history, obesity, diabetes, you can consider checking them around puberty. So that means before puberty, between the ages of 9 to 11, or after puberty, like age 17 to 21, we often recommend checking their cholesterol so that we don't miss those genetic cholesterol disorders that expose you to even the highest risk of developing early heart disease.
So I've been very, very impressed that we've gone 40 minutes into the discussion about diagnosing, about understanding, about explaining to the patient, about really assessing their risk factors. And we haven't even started talking about medications yet. There's one question from Valerie Ann who asked, does hypothyroidism or any other types of diseases affect your cholesterol levels?
Yeah, the answer is yes. There are multiple comorbidities or illnesses that are associated with risk of heart disease. As I said at the beginning, it's not just your cholesterol number. It's your number in the setting of your overall vascular risk. Hypothyroidism exposes you to alterations in your HDL, usually a low HDL, maybe elevated triglycerides.
So hypothyroidism is a low thyroid level?
Hypothyroidism is a low thyroid level, yes. There are inflammatory or other illnesses such as Crohn's disease or arthritis, rheumatoid arthritis, that predispose you to chronic inflammation. Those may increase your risk of heart disease. So the same cholesterol number that someone would have without those disorders, without those illnesses, would mean one thing for you and one thing for another person. So I want to add one thing, Hal, to Tom's prior statement about the timing of. We need to remember that heart disease is a disease of the young. It develops when we're in our 30s and 40s. It manifests when we're older. And so screening early, we do screen, as you said, children. We actually treat children as young as 10 years old when there are familial syndromes with extreme cholesterols. But when you're an adult, you get a screening when you're 20. And if it's absolutely normal, you have no comorbidities, it's every 4 to 5 years. But after that, if you have an abnormality, you're at risk. There is no rule. You have to get that cholesterol down. We check as many times as we need to get you to your goal.
And that doesn't mean we're going to start treatment at a young age right away. Oftentimes when we start screening at a young age, this is the time when we really stress lifestyle changes. So, exercising more, dieting more, changing something in your risk factors to decrease your risk.
So would you say it's important to ask your general doctors if you're being treated for a specific disease, can this affect my cholesterol level? And do I need to be seen? Do they have to be measured? And do I potentially need to see a specialist?
Absolutely.
Yeah, 100%.
All right, so let's transition over. And I know there's a lot of questions that people have been asking about different types of medications for managing cholesterol. So we've talked a little bit about starting people on these agents. So if you wouldn't mind, I'm going to kind of give you a little bit of a shotgun approach to this. I'm going to name the medication that we use to lower cholesterol, that we use to treat problems with your cholesterol paradigm. And then if you could just give me kind of a one-sentence description of how it works and how is it effective, how effective it is. So if you wouldn't mind, let's pick Tomid. Why don't you start off with statins?
Sure, absolutely. So statins are the cornerstone of treating cholesterol. It's our first line agent for lowering your cholesterol level. The way statins works in the liver, and it decreases a step in the cholesterol synthesis. The main thing for you, it lowers the LDL cholesterol the most. One of the medications that lowers it the most. Some statins can lower your LDL cholesterol by 50%, which is very important, especially in those high-risk patients. And the other things with statins, it's not just about lowering cholesterol. There's other things that lead to plaque or heart disease, and that's also inflammation. So statins have been shown to decrease the overall inflammation in your arteries as well. It's what we call like a pleiotropic effect.
All right. So let's go on to another medication that we commonly use in collaboration with statins to really get those people with high levels of cholesterol or people who have had events in the past. That medication is ezetimibe. An, would you like to handle that one?
Sure. So ezetimibe is a medication that works in the lining of our intestinal tract. It reduces the amount of cholesterol being absorbed into our body. When that happens, the liver sees less cholesterol, and in turn, it kind of absorbs more cholesterol from the bloodstream to make up for it. So it reduces the amount of cholesterol by 2 ways. And in addition to the statins that we use, it can reduce our cholesterol 20% more. It has a very safe safety profile, great safety profile, with really almost no adverse effects. Some people report some gastrointestinal side effects, but it's a really safe medication.
I have to say, you guys are really impressing me. I mean, these are the most coherent explanations of these medications that I've ever heard. Again, I want to encourage you to ask questions. I'm going to get to a bunch of your questions in just a second after we finish going through some more of the medications. So, An, since you did such a great job with ezetimibe, what about bempedoic acid?
So bempedoic acid is a relatively new kid on the block. It was approved last year as a new medication that can be used as adjunct to statins. In fact, there are 2 forms, one in combination with ezetimibe. It works like statin, the pathway of building cholesterol or preventing buildup of cholesterol in the liver. Unlike statin, it's a prodrug. What that means is that it's an inactive form of a drug. So when it circulates in our blood, it doesn't interact with the muscles. It doesn't cause the muscle pain that statin causes. And so it's a really good medication. Patients who have are resistant to statin, can't tolerate high doses of statin, so we can add them to a low dose of statin or replace them. And in combination with ezetimibe together, they could reach almost 40% reduction in your cholesterol.
So, Tamid, you get the Jay-Z or the Beyonce of the cholesterol-lowering medications. Tell us about the PCSK9 inhibitors.
Yeah, this is the expensive one, and it's relatively new as well. PCSK9 is a molecule that's found in our blood, and what it does is it prevents, like, it's going to get technical, but it prevents the receptor. It takes the receptor of cholesterol, brings it down, and breaks it down. And what we do with the PCSK9 inhibitor is block that molecule so that the receptors are still out there to take down the cholesterol away from the blood to lower the blood. Ultimately, it lowers your bad cholesterol by like about 60%. It's probably the most effective in lowering your cholesterol. However, given how expensive it is, we don't use this as a first line. We usually use it as an adjunct for people that haven't met their goals with a combination of a statin or Zetia. The other thing with PCSK9 inhibitors is that they haven't shown yet that they have anti-inflammatory effects. So that's why it's always important to start with statins. But PCSK9 is a game changer for people that can't really get their LDL numbers down. PCSK9 will definitely do that for you.
So I get a lot of phone calls from family practitioners, from internists, even some cardiologists saying that, it just takes too much effort to get this medication approved. Is there anything at your lipid center, your cholesterol center, to try and help that process?
So Hal, I think it's become a little easier to get those medications now, but I think that the key is using them in the right place. And we don't see a lot of resistance when we document really well why you're here, what you have, what your risk is, and why you're getting that medication. And when it does happen, we pick up the phone or we send a paper and explain what's needed. And, we get you the medication that you should be on. If it doesn't work, there are other options, and we find creative ways to deal with that. But most of the time, we have a whole team of people who will help us get approval for the medication that you need.
So let me throw out one more medication, and that's Vascepa. Anybody want to handle that?
So Vascepa is icosapentaethyl. What it is a purified type of omega-3 fatty acid derived from fish oil. In the studies, what it really did is it did reduce the triglyceride levels. But what was really interesting is that it reduced the risk of cardiovascular events, independent of reduction in those triglycerides, in the cholesterol level. So it seems like those EPA or the icosapentaethyl levels, or the amount that we can add into, which you can find in some fish and in Vascepa, are protective. It may be an inflammatory process, an anti-inflammatory process, and may be a healthy effect on the lining of the cells and the arterial cells. But it definitely is exciting. So patients with diabetes and multiple risk factors, or patients with prior heart attacks and strokes who have high triglycerides deserve to be on Vascepa. What you need to remember is not to buy the over-the-counter fish oil. Those are fish oils. Those are combination medication. They have fillers. They're not regulated by the FDA. They will not bring down your cholesterol. They will raise your bad cholesterol. They oxidize. They are actually harmful. Fish oil over the counter should not be used.
That's a really, really great point, and can't be emphasized enough. I can't tell you how many people think they're doing themselves a service with that when in fact they're actually doing the opposite. One of the things that at a heart institute like Stony Brook's that we're constantly doing is we're trying to always push the edge and figure out what's better than what we've been doing to this point. And I think there is a medication out there that's in clinical trials that may have a beneficial effect via a mechanism we haven't seen before. And that's a medication called inclisiran. Would anybody like to take a swing at that one? I know, An, you may be involved in a study.
Sure. So inclisiran is basically, to really make this simple, is a molecule that prevents the buildup or the formation of the PCSK9 protein. As you heard from Dr. Rahman, on the liver, on the surface of the liver, there are receptors that clear cholesterol. And the PCSK9 molecule is responsible for degradation or breakdown of those receptors. So when we have PCSK9, we have less clearance of cholesterol. We have higher cholesterol because it can't be taken up. If we can prevent the formation of that PCSK9, then we have a longer duration of those receptors to clear the cholesterol. To make it simple, if we have less PCSK9, if we manage to almost vaccinate you against it, that medication is a medication given every 6 months with a tremendous reduction in cholesterol, about the same as you get with the PCSK9 inhibitors, just with a profile that is safe and seems to need a less frequent injection.
I will say it still hasn't been FDA approved yet, and that's because like the FDA approval process was delayed due to the COVID pandemic. However, it will be a game changer when it comes on because, like Dr. Han mentioned, it's a medication that you take once every 6 months. Going back to the PCSK9 inhibitors like Repatha or Praluent, those are medications that are taken once every 2 weeks. So these are options that can be done for patients that, they want to try another medication that they don't want to keep taking all the time. However, we do recommend that, again, these are just add-on therapies at this point. We always usually start off with statin therapy or Zetia, and depending on the patient and how they tolerate it, we then talk about these medications.
So our patients are constantly coming into us and saying, you know what, I tried statins, it gave me muscle aches. I read it here on the label, it causes muscle aches, I have muscle aches. Or they say, my memory hasn't been as good while I've been on statins. Can one of you definitively, once and for all, just tell us what the data is? Do statins cause muscle pain, and do statins cause memory loss, and are there any other side effects we should be paying attention to?
So look, statins are maybe the most studied medication we use in medicine overall. Maybe have the most randomized control trials, the most robust, and the highest number of trials of all medication we use in medicine. They're mature. They've been used since the 80s, studied in over 500,000 patients. And we know unequivocally that they're safe and they reduce outcomes. They reduce cardiovascular outcomes, stroke, heart attacks, and prolong your life. There are side effects to any medication. It's only that we couldn't really prove those side effects when we did our randomized trials. What that means is that when you got statin or you got a placebo or a sham medication, we couldn't tell the difference between patients who have symptoms or not. You may have had symptoms on the sham. And so maybe there's an anticipatory effect, because statins could cause muscle pain. It's just that it doesn't happen as often as we think. We do have ways to deal with it, and we can talk about it in a minute. It does not cause dementia. It does not cause cognitive dysfunction. Studied multiple trials in multiple ways. It does not cause diabetes. However, if you do have pre-diabetes, you're almost diabetic. you're going to become diabetic. It may push you over the limit a little sooner, but patients who have that, who are pre-diabetic, are going to turn to diabetes, benefit from statins more than others who don't have diabetes and should be on it first.
So let me run down a couple of quick questions. If you guys can keep these brief, because we are pushing up against time. There are some people who are asking about supplements. Mary Ellen asks about turmeric.
So with supplements, again, like it hasn't been studied with supplements. However, we don't know. I mean, it could be good, it could be bad. However, if you feel like it's working for you, it can help. Turmeric, there hasn't been really much data. It may lower cholesterol in some studies, but there really haven't been any real randomized control trials looking at that. But when it comes to supplements, again, if you're not experiencing side effects, you can continue taking it, but don't expect for a dramatic change in your outcomes because we're not sure if it really does or not.
What about a multivitamin with niacin?
Niacin has to be at a certain dose to cause a positive effect. And it does have adverse effects. It has not been shown in trials, in clinical trials, to have a great effect, a positive effect on our overall cardiovascular outcomes. And so we use it, we just don't use it often. And so I don't know that in a vitamin it's useful.
All right. And Jill asks, can you take a statin drug if you're on immunosuppressive infusions?
So yes, when it comes to statins and immunosuppressant infusions, these are questions that are really great and handled at a lipid clinic as well to make sure that we can spend the time to see if it's interacting with your meds. Oftentimes there are statins that interact with, let's say, a transplant patient that's taking tacrolimus or cyclosporin. We might have to substitute your statin for a different statin that won't interact with those medications. So it's very important to always speak with your physician to see that when you're about to start a statin, that you tell them what medications you're taking. And we do spend the time to make sure that those statins don't interact with the immunosuppressive therapy that you're taking. The main thing here is they could cause the statin effect to be more potent, and you might experience more of the muscle side effects with statins if you're also taking like an immunosuppressive medication, depending on what statin you're on.
Okay, and so we always get that question about red yeast rice as a natural statin. Anybody want to comment on the potency?
But basically, red yeast rice is lovastatin. It is a statin, only that we can't gauge how much you're getting. So if it's unmeasured, it can cause side effects. It may reduce your cholesterol by up to 20% in higher doses. Having said that, I think that if you're going to be on a statin, you might as well take a medication that's regulated, measured, and we can, really have an expected effect with. I don't recommend it usually.
Like another thing to add on to that is lovastatin is a low potency statin. We have moderate intensity statins and high intensity statins. And if you're at high risk, then red yeast rice is not going to do enough for you. These are the patients that need to be on the high potency statins like Crestor, like Lipitor, for an actual benefit to be seen.
So you're going to see that their cholesterol levels are not really lowered dramatically on the red rice, on the red yeast, so they can prove it to themselves if they need to or if they want to. But pay attention to your numbers. What about apple cider vinegar? That's something that we're seeing as a cure for COVID and also the lower cholesterol. Any data on that?
I honestly haven't seen any data about apple cider vinegar and cholesterol levels. I will be quite honest. I actually take apple cider vinegar myself. What it has shown is it could kind of like decrease your hunger, maybe regulate your insulin levels throughout the day. But there's no real studies that have shown that, but it is something that I do take personally.
So let's pivot a little bit, because I've heard, you guys have been great. You really have defined the problem. You've told us what to do as far as testing. You've given us options. You've told us how to modify our lifestyles, and you kind of went through all the medications. So why does Stony Brook have a specialized center for advanced lipid or cholesterol management? What's the value added that a person coming to your clinic will hope to achieve?
So Hal, I think the answer is a fewfold. I think that first, we know that heart disease is preventable. And I think that the sooner we intervene, the better. I see it firsthand. I see patients with heart disease. I have to fix it. And sometimes I just never want to go back in there. And if I could do something to change that, it is being really aggressive about changing that cholesterol. And so when you come to a clinic versus just going to a physician, it's the system. It's the constant access. It's the ability to have a system in place rather than just seeing one doctor. I'm not saying that I'm better than the next guy treating cholesterol. I want to think that. But when I have Tamid, when I have Sahana, when I have my nurse, when I have all the other systems that I use, whether it's bariatric surgery or weight loss clinic or a nutritionist or cardiac rehab or all the vascular imaging and all the systems that I have, allows you to have a more consistent care. And it's actually been studied. And when you go to a system rather than to a physician, you have better outcomes. It's the follow-up that we allow. I think those are the key things. You need to remember, when you come to our clinic, we're not there to try and test your cholesterol or get you a CAT scan or get you on a medication. We want to reduce your outcomes, prolong your life, and give you a life free of disability and cardiac events. And to do that, we have this entire team in place to support you. I see you, then you have a follow-up within 4 weeks to check your results with Sahana, who then sends you back to me or changes your regimen on her own as soon as she needs to, and then you see us again. So it's a little more robust than just going to a physician.
The other vision that I have for this is it's not just about yourself as well. There's oftentimes where we are trying to diagnose more of the genetic familial hypercholesterolemia patients that have the highest risk of heart disease. It's not only treating yourself, but we also offer genetic screening for you, and then we also offer cholesterol screening for your family members. And I'm hoping that with this clinic, and we do get this a lot, where a patient is diagnosed, we also get their family members coming to us to assess their risk as well and see if they have any other familial conditions or just a genetic or high risk predisposition as well. So it's an approach to kind of partner with you and treat you as well as your family to assess your risk as well as the risk of your loved ones as well. And that's what we're trying to achieve here with all the facilities that we have and all the different partners that we work with in our Stony Brook clinic.
We actually have a tumor board. We meet once a week. We review all our active patients. We review the results, discuss what the next step is. We make sure that they're notified, that our nurses call them, that are brought in to do what they need to do, that we get that approval for the next medication, that a script for the next follow-up, for the next blood test is done. So, I think that when I used to do this alone, there were limits to how much I could do. And now it's a lot better. I think that the system works much better for you.
And just to add to it, I'm always in the clinic available to discuss results with any medication changes or do another cholesterol check. So I'm always there for everybody, for all the patients.
So let me take a question from Valerie Ann and kind of extend it a little bit. So if I'm hearing this, or I have a loved one that I'm concerned about, how does that person go about getting a visit with you at the Lipid Center? And Valerie Ann asked, is the care at the clinic covered by most insurances, and is a referral needed?
The answer is you call 631-44-HEART, you get to the Stony Brook Heart Institute, and you ask to see someone in the Lipid Center, the Cholesterol Center. You can ask specifically for Dr. Rahman, myself, or Sahana. It is covered. It's like any visit that's covered by Stony Brook University. So they will figure out for you whether your insurance is accepted.
The other thing to add to that is, we do have multiple sites. So depending on your location, I'm usually over at the East Setauket office, and Dr. Hen is usually over at the Comac office. So, depending on the location that works for you, just call the number, set up an appointment, and we definitely be available to help you out and get you along on the journey for tackling your cholesterol.
So let me run through a couple of scenarios, and you tell me if you strongly suggest a person comes to the Lipid Center and Cholesterol Center, if you moderately think they should come to the center, and if you think that their general cardiologist or their internist is perfectly capable. Somebody who has had prior blockages in their arteries or recurrent events that have taken them to the hospital with multiple heart attacks or blockages in the arteries of their legs or brain.
Yeah, I mean, these are the very high-risk patients, and these are the patients that if their cholesterol is still not controlled, or even if their cholesterol is controlled and maybe their triglycerides are not controlled, we need to be more comprehensive of how to tackle these very high-risk patients and their cholesterol panel and their risk factors. So this is a patient that should definitely come see us in the clinic.
I agree. I think our European counterparts are even more aggressive than we are on defining what their goals are, or they would push a patient like this to a cholesterol of less than 40, and I don't believe there's a too low of a cholesterol to get to. I have patients walking around with cholesterol in the single digits.
So, what about people who have been managed with their cholesterol, but they're not getting to goal, where the doctors have been saying, it looks well enough, either due to side effects or due to the fact that the agents that they're using, seem to have been at the highest doses that a doctor feels comfortable?
I'll tell you, our current guidelines changed from having cutoffs to having thresholds. What that means is that they're very clear about the fact that if you are above a certain number, you should intensify care. And there's a reason. The reason is that they want us to be more aggressive. They want us to drive the cholesterol down because we know what it does and we know the benefit from it. And so if your bad cholesterol, when you're at risk, is over 70, and at 71, you need to have that next medication added or the next change in your diet or discussion of what's causing this, and not just leave it alone and recheck it.
And often it's a challenge because the patients do experience side effects, rare, but it can happen. And, it may be a lot for a physician to handle in the community or, one of our partners as well, too. So oftentimes what we recommend is getting an assessment and coming up with a strategy that might work. And we have other ideas of maybe trying different statins, switching you from to a more hydrophilic or water-loving statin, switching you to another medication that might help. So I think it's very important to have that discussion and spending the time with the patient to really help you through your intolerance, side effects, and finding another strategy. Because again, we got to lower that risk. We got to lower that cholesterol.
So what happens if you have a cardiologist or a doctor that you absolutely love and adore, who has saved your life multiple times, but they can't get the cholesterol levels under control? Are you taking those patients away from those doctors, or do you work together with them?
We are not here to take you away from anybody. They have done a great job, in fact. If you had heart attacks and you're still here, you're in good shape. We will work with you and your doctors to get the cholesterol down, get your risk down. And with your values, we will work with your physician's thoughts and we'll find ways that are, to help you. But we're not here to take over every aspect of your care. And so we'll communicate with your physicians and help you get to where you need to get.
So if you haven't had your cholesterol checked, should you run to the lipid clinic, or or are you recommending that they seek out their internists or their general cardiologists?
Yeah, I mean, for that initial test, you should always discuss it with your primary doctor, the doctor that you're the most comfortable with. If you already have a cardiologist, then continue following with your cardiologist. They should be able to be the one that does the initial screen and start you on the initial plan. It's really when it comes to the more intolerant patients or the more advanced high cholesterol patients that are very resistant and don't drop that would come see us or get referred to us.
Right. So I want to thank everybody for all the love that we're seeing in the comments section. Many things that we didn't have a chance to get to. But I'd like to close it, if you guys wouldn't mind, on a personal level. So what do you guys individually do to control your own cholesterol levels? Sahana, you wanna lead us off?
Sure, Dr. Skopicki. So to keep our cholesterol levels under control, for myself, I love eating home meals. No processed food for me. I love eating home meals, freshly cooked. And my meals includes bowl of salad, vegetables that I grow in the garden and I eat them. And also fish. That's my favorite. I can eat fish 7 days a week, fresh fruits, sometimes seasonal. I also go into the garden and get figs for myself, which is nutritious, low calories. And I also bring it for Dr. Hen sometimes. Um, and last but not least, I also have a small piece of dark chocolate.
So we'll be giving out Sahana's home address at the end of this.
You're
That's
all welcome.
As long as they're not taking the dark chocolate she brings for me and they leave, it's fine.
It's unsweetened though. It's not like sweet.
Dr. Alman, what are you doing to control your cholesterol levels?
So I'll be quite honest. Weight was a struggle at the beginning, and with my risk factors, I'm from Bangladesh. I'm from South Asia, and we have one of the highest risk for heart disease. The other thing is with my genetics. My parents both have diabetes, and I was really uncontrolled with my diet when I was going through the stress of med school and residency, and the stress of working with Dr. Hen. But no, for real. Honestly, it got out of control, and once I got diagnosed with diabetes, I actually had to take control. So what I did was cut out the sugars, and I stress cut out the soda, cut out the juice, switch it with water, and that made the biggest difference. And I got my A1C down to a level that's even better than pre-diabetes. With my risk and my genetics, I've actually put myself on a statin as well. I've gotten prescribed, talking to my physician, and after talking with them and assessing our risk, it was important that I lower my LDL as well as my triglycerides. So, I've switched to water. I've started cooking more instead of going through the drive-through diet, and I've started taking a statin to really decrease my risk for heart disease. And I'm really happy. I'm tolerating the med, and it's really worked well for me. And I feel very confident with decreasing my risk down the line for heart disease.
Dr. Hen, you get the last word on what you're doing to keep your cholesterol under control.
I've been told by someone who's listening today that I ride my stationary bike like it's my job. And I try to keep a Mediterranean diet. As you heard, I think that it has to be sustainable, it has to be satisfying. And so sometimes I'll have a piece of dark chocolate or a steak, but I try to keep a Mediterranean diet.
So one last plug. I think what you can see, are three absolute experts in front of you that really have the answers to questions. I think the thing that I took away from this was the fact that, number one, you need to have a discussion with your physician. You need to know your numbers and you need to know what they mean. Number two, if you have numbers that are not looking the way they should, that you have risk factors or a history in your family or in yourself, you need to have a good doctor taking good care of you, and it needs to be in a collaborative way. And if that cholesterol is difficult to modify or you're having recurrent events, you need to seek out specialists who can offer you the best chance at living your best life. So I want to thank our three panelists and especially you for checking in on us and for listening to some of the insights that we have. And please feel free to reach out to Stony Brook when you need that care or you need that answer. We're here for you. So have a good night, everybody.
Good night.
Thank you.
Good night. Thank you.